So wonderful. I want to welcome everyone for joining us. I still see that we have a number of people who are connecting and joining us online, but I want to get things rolling as close to being on time as we can. So I just want to welcome everyone to Our Community, Our Health. This is a town hall series in which we share a number of ideas about health, prevention, and treatments that impact our community. My name is Dr. Michael Jaffee. I have the privilege of being the Vice Chair of Neurology and the Director of the UF Brain Injury Rehabilitation and Neuroresilience Center, which we call the UF Brain Center. And so on behalf of all of our Brain Center members, we are pleased to have all of you join us today. And I am privileged to be your moderator for today's town hall with our very distinguished panel. The town hall itself is entitled Long COVID, It's Not All in Your Head. Our brain center is unified around the theme of acquired injury to the brain from a variety of etiologies. And in dealing with the pandemic from the past several years, we have been reminded about the effects of viral infections on brain structures and brain function, and how these effects can interface with possible other brain vulnerabilities. Today's session, we are hoping will place these issues in context. For any future Brain Center activities, you can always check out our website and join the follow us on Twitter, and we will have some of those addresses in the chat for people who are interested in continuing to follow the UF Brain Center. Today, we actually have two panelists from the University of Florida and one who is currently in private practice in New York. And we're going to start off by talking about some of the acute issues of COVID. We'll move on to some of the more chronic physical issues and then focus in on some of the emotional and cognitive issues, trying to put all of these together in context and then have time for some moderated questions and answers. So starting us off with better understanding some of the acute neurological effects of COVID, we're going to hear from Dr. Christopher Robinson. He's an assistant professor of neurology and neurosurgery and the program director for our neurocritical care fellowship at the University of Florida. He is the principal investigator for our NIH-funded Boost 3 trial. That's a randomized clinical trial to help determine the comparative effectiveness of two strategies for monitoring and treating patients with traumatic brain injury in the ICU setting. He has published extensively on brain death, meningitis, traumatic brain injury, subarachnoid hemorrhage, and more recently, COVID-19 associated neurologic complications. He was at the forefront of investigations into encephalopathy as an early marker of severe COVID-19, and I'm very excited to hear from Dr. Robinson.
Thank you for that nice introduction, Dr. Jaffee. Welcome, everyone, and thank you for taking time out of your day to hear a little bit about what we have to say. So can someone verify that they can see my screen, please?
Yep.
All right. So again, my name's Chris. I'm a intensive care doctor as well as a neurologist. And the title of the session today is Long COVID. But before we get into long COVID, which would be your long-term complications of the virus itself, we need to talk about the acute effects and what we have found and what we see with the virus. So since 2020, my group has been on the forefront of COVID from the critical care perspective as well as the neurologic perspective. Let's see if I can get my screen here. So we have to talk about viruses in general. And so in order to have a neurologic problem related to a virus, the virus itself has to somehow get into the central nervous system or the peripheral nervous system, so the brain or the nerves. And so this is referred to as something called neurotropism. The virus itself can find receptors and enter into the brain or the nerves. There's several ways that viruses can do this. They can enter specifically into a cell and go into the brain. They can go between cells, or they can actually get attached to some of the nerves, such as those with smell and taste, and go up into the central nervous system. The most common way of spread that we see with acute viruses, however, is something called hematogenous spread, where the virus affects the entire body and it circulates in the bloodstream and gets to the organs in which it wants to go. So what about the term coronavirus? Most panelists here were very familiar with this type of virus as they graduated medical school and for some time, but now the general public is quite familiar with this virus. It's a family of RNA viruses, and typically it affects both birds and mammals. It has a propensity to want to infect the respiratory system. Now that includes all the way from the nose down to the bottom of the lungs, as well as having some effects on the central nervous system or the brain. There's very well documented coronavirus particles in neuronal cells and brain cells over the history of time. And before we had SARS and SARS-CoV-2, we talked about coronaviruses in the setting of alpha and beta coronaviruses, which is different than the variants that we're talking about from COVID-2. These viruses have been endemic worldwide for quite some time, and they cause your typical common cold symptoms that we're used to. So we published a pretty landmark paper in early 2020, March of 2020, comparing coronaviruses and other SARS viruses that have occurred in the past and what the neurologic manifestations of those viruses were. Some of the things that we found were encephalitis, or simple infection of the brain, seizures, or something called refractory status epilepticus, which is seizures that do not respond to seizure medications, acute demyelinating encephalomyelitis, which is an autoimmune reaction where the body itself attacks the brain tissue, acute inflammatory demyelinating polyneuropathy, or Guillain-Barré syndrome, is something that we found with coronaviruses prior to SARS-CoV-2. Leukoencephalopathy is a specific targeted destruction of the brain that can be pretty dramatic and has a high mortality. Critical illness neuromyopathy is a condition in which patients acutely affected with the virus lose the ability to move their arms and legs due to destruction, not only from the virus, but their illness of the nerves and the muscles. And then we found several preclinical or mouse models that show coronavirus encephalitis occurs in mice, or infection of the brain, because the virus itself specifically enters the brain. So in 2019, our world changed. What we found is actually that SARS-CoV-2 is very similar to the SARS infection that we were familiar with coming out of China 20 years ago. We knew that it caused acute, highly lethal pneumonia, which we termed COVID-19, and it was associated with profound hypoxia or loss of oxygen. The other thing that we discovered as time went by and we collected data is there's something called a cytokine storm. That translates to a systemic release of inflammatory cells that can result in any organ becoming dysfunctional, whether it be the heart, the kidneys, the blood system, the brain, further damage of the lungs. And in fact, it became part of our treatment algorithm as we move forward in acute coronavirus care to try to treat these storms with specific medications targeted. We've also found that patients with acute coronavirus have something called microthromboembolism, where they form blood clots everywhere. Now, whether this was in relation to the virus itself or the systemic illness and the inflammation that was occurring, which probably is the latter, invariably this would occur in multiple parts of the body. And the ACE2 receptor is the receptor that SARS-CoV-2 prefers to bind. And when you look at the variants as we move through time, you find that these different variants bind to different ACE2 receptors in different parts of the respiratory system. So the early coronaviruses like to bind deep in the lungs. You can hear Dr. Fauci talk about this, where the new variants like to bind in the upper airways.
Every other.
So if we look at the neurologic manifestations, there's two things we need to think about in the acute setting. Is the problem the patient's having with their brain or nerves due to the immune system or due to the virus itself? Those are two very different things. So the only reason that we feel sick when we get infected with a virus is due to our immune system acting upon that virus. Those fevers, those headaches, those body aches are our immune system working at overdrive. So when we looked at the patients with brain issues related to COVID, the non-immunologic causes were related to general infection and critical illness. So patients were not getting a lot of oxygen. Therefore, their brains were not getting a lot of oxygen. Their blood pressure was very low because they were septic, and therefore their brain was getting reduced blood flow. And then due to the systemic cytokine storming that was occurring, all of these clots were forming, and perhaps patients were getting strokes due to that, not because the virus specifically was attacking brain cells. What we found more significantly is the immunological effects. So that Guillain-Barré syndrome, that acute demyelinating encephalomyelitis, that critical illness polyneuropathy was related to the immune system in the brain and in the body, which are separate, becoming highly active. So when you look at all the patients with acute coronavirus and you compare it to other viruses, and then you compare it to the general population who do not have a viral infection, the acute neurologic problems associated with coronavirus are actually less than the general population without being infected with the virus. So acute stroke occurred in 2.6% of patients. And you have to think about what else is going on with these patients. Are they on blood thinners? How sick are they? Is the stroke itself directly from the virus? And the answer is usually no. And if you look at the acute stroke risk in the general population without being infected by a virus, it's upwards of 3 to 4% and sometimes 5% in different populations. Patients have bleeding in 1%, which is less than the general population, meningitis 0.3%, Guillain-Barré syndrome 0.6%, and autoimmune reactions 1%. So significantly less than the general population. And this we found correlates with other viruses, including flu, including the other coronaviruses, including RSV, for example. So there was no statistically significant difference. So if we look at, continue with this paper, the most common acute neurologic manifestations were those that we all complained about when we got it. We were tired, our muscles ached, we couldn't smell, we had some shortness of breath, and we lost our taste. And if you look at the significance, it's actually these acute changes that occur most frequently and significantly higher than other viruses. However, I will say at this point, there was no report on long COVID. Long COVID was not a thing, right? We didn't know what the 6-month manifestation of this virus would be. So this is an interesting study to kind of wrap acute coronavirus. So these are neuropathological features of COVID-19. At present, there's 41 patients that we've looked at in the literature. And this is after a patient becomes deceased from coronavirus, we look at their brain and see what happened. What we found in these patients is that 50% of the patients were admitted to the ICU. And interestingly, 27% died greater than 4 weeks after COVID infection. Now, I'm sure there's people here that have had family members infected with COVID in the early stages, and the hospitalization is quite long. So there is some variance there. What we found was there was significant loss of oxygen in all the brains, and that there was some ischemia related to that or damage of the brain due to that loss of oxygen. But what's important when brain doctors talk about strokes, we want to know, did the brain bleed or was there a clot? In these brains, there was no evidence of clots. The brain injury was all related due to loss of oxygen. What we also found in all the patients that passed away and had brain features, they had severe atherosclerosis, which is related to probably high cholesterol levels. Most importantly, in the meat of the paper is we found low levels of coronavirus in all the brains. However, it was significantly lower than any other organ system in the body. And there was no damage to the smelling nerve when we lose our smell. So questions remain, right, after we talk about the acute phase. So the virus itself doesn't cause more acute complications than other viruses. But it does have this systemic inflammatory response that we kept seeing causing a majority of other problems. So what are the true long-term complications? Are they neurologic or are they perhaps systemic and inflammatory in nature? And that's why they are ongoing. And given the lack of the brain pathology changes, what role does the immune system play? Thank you.
All right, so Dr. Robinson, thank you for kind of laying the groundwork for us on the acute effects of COVID and then laying the foundation for some of these emerging questions we're having on the long-term or long COVID effects. One of the things I do want to mention is that with our community, our health, it is one of the goals is to get engagement from the community. And so this is an opportunity for people as they hear these presentations to make their questions known. And so you can, using the chat function, type in what a question is, and then we'll kind of help moderate that when we get to the question and answer part of the presentation. And for those who are not able to stay with us for the entire duration, there is a poll that will be available. So we do ask people to complete the poll on the effects of this town hall and their thoughts and feedback that we can always work to make things better for the future. And so those are ways we want people to get engaged. We want people to ask questions and to take time to complete the poll before they leave, because we want you as part of this conversation. And so with that fine foundation that was laid by Dr. Robinson, we're going to move on to our second speaker, who is Dr. Irene Astores, and she is an associate professor in the Physical Medicine and Rehabilitation Department. She serves as the medical director of the Integrative Medicine program here at the University of Florida. She completed her Integrative Medicine Fellowship at the University of Arizona Center for Integrative Medicine, which is a nationally recognized program of Dr. Andrew Weil, and she did this as a Bravewell Fellow. Dr. Astores is a member of the American Academy of Medical Acupuncture, the American Society for Clinical Hypnosis, and a board member of the American Board of Integrative Medicine. In light of the pandemic, she has helped develop a registry for patients with long COVID and has helped develop models of care for post-acute COVID-19 clinics. And I'm looking forward to hearing more about that. So, Dr. Astores.
Thank you. Let me put up my slide. And make sure that I am able to share it. Hold on. This is always or frequently. Let me share my screen first. Okay, share. Can you see my screen now?
I can see a screen, but not a PowerPoint.
Okay, so let me stop that. And how about now?
Yes.
All right, thank you. Let me. My slide is not advancing. I am sorry. Let me just.
Maybe if you hit the slideshow in the bottom right. Kind of move it into presentation mode.
Bottom right. I'm. Yeah.
Oh,
Can I just scroll from here and
let's do it that way.
All
Yep.
right. I apologize for this, but thank you and good morning to our participants. I'd like to pick up from what Dr. Robinson mentioned and talk about the post-acute and chronic management of patients after COVID-19 infection. I would be remiss if I do not recognize the advocacy of persons living with long COVID in bringing us towards a better understanding of the mechanisms to explain why this is happening and to find ways of managing it and hopefully at some point treating it. This is an infographic that shows the multiple symptoms that can come about following COVID. And I bring this up because I want to show you that this affects multiple systems. And the other nature of this condition is that it is multiphasic and cyclical. So we need to see that all these symptoms can happen at the very beginning or can happen later on or resolve and then come back. Or there may be new symptoms that develop. This is one of the mysteries that we are trying to find answers to as we study this condition. I'm going to focus on fatigue, not only because it is the most prevalent, but also because it is very functionally limiting and it affects our ability to think. So it really affects cognitive processes and it affects our emotional and mental health. So this is the line that we want to see. We want to see that from acute COVID, we would have full recovery. But unfortunately, we see that there is another line here. And if we look at the current data, they say that 1 in 5 of persons who develop COVID will develop some long COVID symptoms. And that, of course, is an estimate because we still are still having some debate about how to define the condition. But using the current definitions that we have from the World Health Organization, the NIH, we are coming closer to defining this as a condition that we see that happens after about 2 to 3 months following the initial infection. So we see this. We see that 1 in 5 people develop long COVID. And we know that it is a real condition because we, in the past 2.5 years, we have come a long way in demonstrating plausible mechanisms for the symptoms that we see in long COVID. So as we see here in this, so viral antigen persistence, inflammation, immunological responses, as mentioned earlier, microvascular dysfunction, gut dysbiosis, and reactivation of other viruses. And our hope is that as we know more about this, we can move this line from this place to full recovery. And it may come from any of these. But in the meantime, we do have to work with people who have these symptoms. And so let's focus on fatigue. And fatigue in long COVID has a different flavor from the fatigue that we see following other post-viral illnesses, or fatigue from hard workout, or fatigue from not being able to have a good night's sleep. And one of the central symptoms or central features of fatigue seen in long COVID is what is termed post-exertional fatigue or malaise. So this is the fatigue that is experienced even with minor physical or mental exertion.
This is Dr. Jaffee, Associate Chair of Neurology.
So, and this worsening of symptoms can happen typically about 12 to 48 hours following that episode. As I said, it could be just minor physical or mental exertion, like your basic activities of daily living or driving. And this fatigue can last for as long as days or even weeks. This is also the fatigue that is described in another condition that we call myalgic encephalomyelitis, or chronic fatigue syndrome, ME/CFS for short. Not only is there exacerbation of fatigue and malaise, but there could also be exacerbation of other symptoms that I've already shown you can be seen in long COVID. So difficulty in thinking, or increase in pain, increase in tinnitus, or problems worsening of smell after minor physical or mental exertion. So this is more than just physical conditioning. And so the key is not to tell people to just exercise more, or you just have to push yourself or work harder. We need to recognize that we are dealing with a different kind of fatigue. So the rehabilitation that we do for these patients have had to be modified. And because I am a physiatrist, physician who specializes in physical medicine and rehabilitation, the focus of core component of our program is this rehabilitation component. We have these other components, and this is the reason why I am part of this panel, to reach out to the community and find out how we together can develop ways to improve the care of patients with long COVID. So fatigue can be assessed in many ways. There's a specific questionnaire. This is called the Depaul Post-Exertional Malaise Questionnaire. This was also developed for patients with ME/CFS. But because we have no other questionnaire for long COVID, we are using this as well in our clinics. I think that there is a validation study being done to make sure that this also can be used and be valid in the long COVID population. We use this so that patients can also be aware that they can do something to modify the fatigue that they're experiencing. There is a more objective form of testing called cardiopulmonary exercise testing. This can be done, this is already in place. This is not something new. This requires patients to exercise using typically a bicycle ergometer. It is monitored using an ECG, and the gases are also collected to measure levels of oxygen and carbon dioxide. This is done in 2 phases, and we compare how the patients perform between the 2 sessions. This is a way to document it more objectively because some of the insurance carriers require that, especially as people file for disability following long COVID. This is not done routinely in our clinic, again, because of the cost involved and because I don't think that this is something that will be pushing these patients this much will actually be detrimental to their recovery. We teach patients how to pace. Pacing is probably the core skill that we tell our patients they need to develop in order to manage their symptoms, not just fatigue, but all other symptoms. There are other ways to work with patients with autonomic dysfunction. So there are modified protocols. For autonomic dysfunction, we call the Levine protocol. It's a modified Levine protocol. We do breath retraining, diaphragmatic breath control, breathing through the nose, breathing slowly. These are things that can be done behaviorally to modify symptoms. There is actually an app for breath retraining that was developed from one of the labs in Mount Sinai. This was a lab that was part of their long COVID program. But we can teach this to our patients. And the last thing is we tell them to titrate their physical activity using their symptoms. So the movement that is best for them is the movement they can recover from. This amazingly is something that is not yet recognized by other rehabilitation professionals. We are still in the process of sort of making a case for this, but we teach our patients that this is something that will aid this recovery. The infographic on this side shows what is called the spoon theory, though this is something from the Dysautonomia literature, again, to help counsel patients on how to pace themselves so that they can manage their symptoms. And as I mentioned earlier, there are trials that are ongoing to find out if there's anything specific that can be done to treat the underlying mechanism for this post-exertional fatigue and fatigue in general. So one of the proposed mechanisms for this is mitochondrial dysfunction. So these 2 compounds are being studied to find out its effects on post-COVID fatigue. And then I bring this up because this actually just came out in Nature. So this is already peer-reviewed. It is a small study, only 73 patients, but this came out of a group in Israel. And they were looking at the effect of hyperbaric oxygen therapy. So as someone who practices integrative medicine, I hear a lot from my patients about all these other kinds of therapies that are different. So hyperbaric oxygen therapy is something that I hear often from my patients. And so I'm glad that they have finally completed this study. And so they have noted that with daily sessions of hyperbaric oxygen therapy, these are patients with confirmed COVID-19 infections about 3 months out of their acute infection. With daily sessions, about 40 sessions, they have found improvements in these cognitive domains and some changes in the brain microstructure and perfusion. What I can say is that this is good that we have this initial data, but it is small. The follow-up was short. They only tested the patients 1 to 3 weeks after their last session. And of course, there is the issue of cost and access. So I truly want to bring this back to how it is important for us to study this more. And so, as mentioned earlier, our department has a registry for patients with long COVID. This is basically a contact registry, and you are the persons who participate in this registry basically give consent to be contacted by other UF researchers who are interested in doing specific projects or studies for long COVID. And we have a wealth of researchers at UF who are really committed to understanding this from the most basic standpoint to translating what we already know into clinical practice. So with that, I thank you for your participation in today's webinar and look forward to the discussion later.
Thank you so much. I do see that there are some questions that are coming in already on the chat and Q&A. I encourage people to continue to enter those so that we can, so that we'll have some great questions ready when we get to the moderated questions aspect of it. And so I want to thank Dr. Astores for laying the groundwork for us, for telling us about some of the long-term physical effects of COVID. And that kind of helps us transition to our final panelist, and that's Dr. Goudrun Lang. And she is a clinical neuropsychologist in private practice with over 24 years of experience in the field. She earned her degree in clinical neuropsychology from the CUNY Graduate Center and completed her postdoctoral work at Memorial Sloan Kettering Medical Center. Her research has focused on populations that have experienced concussion or mild traumatic brain injury, Gulf War illness, myeloencephalomyelitis or chronic fatigue syndrome, and fibromyalgia, as well as more conventional diagnoses, including cerebrovascular events, neurological conditions, and cancer-related cognitive dysfunction. She currently sits on advisory panels at the Centers for Disease Control and the NIH and the Neurological Institute for Neurological Diseases and Stroke. Her current work is focused on long COVID, and I look forward to her presentation focusing on some of the cognitive and emotional aspects of long COVID. Dr. Lang.
Thank you, Dr. Jaffee. I'll try and do the share screen thing. Okay. Okay. Can you see this?
Yes. Thank you.
So thank you very much for inviting me to be on this panel with Drs. Robinson and Astores. And I was so happy to hear from Dr. Astores that there is a more enlightened approach to rehabilitation of long COVID symptoms. What I will be focusing on is on the cognitive aspects of the condition, which is one of the more disturbing ones. And the information I'll provide comes from my experience with patients who suffer from ME/CFS, as well as from long COVID. The most common presentation of cognitive problems involves poor attention, poor processing speed, and poor working memory. That's not to say that there are not patients that have other presentations, but this is the most common one. What the common complaint is of patients that I see is that they have difficulty with learning and absorbing information, perception of memory problems, difficulties with executive function, including planning, sequencing, and organizing, and majorly difficulties with multitasking. So those are upstream consequences of poor attention, attention deficits, deficits in sustained attention, processing speed, and working memory. The perception of cognitive problems in clinical practice is often expressed in these ways. I feel like I'm in a fog, like my head is in a cloud of cotton balls. In a business meeting, I'm only able to absorb early information then the words just wash over me. My headache increases when I work on the computer. Many of my patients have to wear blue glasses or sunglasses to be able to do computer work at all. I have a hard time to maintain attention when I do computer work. I drift off and have a hard time to pick up again. So this particular issue arises when people have the perception that they are responding in a timely fashion, but they cannot sustain that timely response. It goes up and down and up and down. And so therefore there is a lack of absorption of critical information. I was always good in math. Now I'm making so many mistakes. Many of the patients I see are extremely upset and frustrated with what they feel is cognitive decline. And many express the following: have I just gotten stupid? Am I dementing? And so that puts a lot of pressure on patients and increases the potential for a post-exertional malaise, as Irene was already alluding to. I have a hard time to have even brief conversations on the phone. And I will be talking about that briefly in a minute or so. This one is often a frustration expressed when patients have to talk to their relatives, family members, friends who try to be helpful, but the patient cannot tolerate that much interaction. And I generally give people pointers on how to deal with that. Then I'm wearing sunglasses in my home because the sunlight hurts my eyes. In addition to sunglasses, people wear ice hats, 2 sweaters because they are not regulated properly temperature-wise. And so the whole life that they had known before they became ill with COVID and are now suffering cognitive symptoms of it has changed. As Dr. Astores was mentioning, many people have to file for long-term disability because their COVID symptoms are not remitting. And among the ones that are functionally related are cognitive problems. So they are referred to me as a clinical neuropsychologist. Like other assessment tools, cognitive assessment is not cheap. So many primary care providers that I spoke to have asked whether I'm familiar with a tool that they could use for screening so that when they're working up the patient, they can at least have an objective screening tool to figure out whether there is a cognitive deficit. And there is some literature on people using the MoCA clinically. And I've talked to several providers that are using this tool as well, this screening tool, and it's informative. However, cognitive problems are not always detected on screening. That's why many patients have to go on to be evaluated by a clinical neuropsychologist. They are undergoing a battery of cognitive measures that include assessment of overall intellectual functioning, basic visual, language, and motor ability, concentration and attention, information processing speed, learning, short and long-term memory, including working memory, as well as planning, sequencing, and mental flexibility. This battery takes about 6 to 8 and sometimes 10 hours. I am currently administering this battery remotely. The standard administration is face-to-face. So there are caveats that have to be paid attention to when there is a non-standard evaluation happening. However, this is a topic that has been discussed fairly vigorously in my field, and more papers and reports are coming out suggesting that the standard tools used in face-to-face evaluation also are valid in a remote setting. But again, one has to be aware of it. In addition to the cognitive evaluation, a report also needs to include documentation of emotional function and functioning and activities of daily living. What I do is I see patients over 4 days, 3 hours a day via Zoom, because Zoom activity, computer activity is extremely tiring. And I don't want to torture people and get them into PEM. So I try to titrate the evaluation over 4 days. And each day I evaluate on a visual analog scale the patient's fatigue, headache, body pain, whatever it is that is constantly there impeding their function. I do that at the beginning and at the end of each session. And then I ask them to provide me with a diary of their life after we're completed with the evaluation over 5 to 7 days. What happens generally is that people have to take to bed after the cognitive evaluation. I talk to them about this potential before we engage in the evaluation. And so their post-exertional malaise secondary to the cognitive evaluation generally requires that they take it really easy for several days, at least 2-3 days, sometimes 5 to 7 days. So what is happening to me? This is a crude cartoon, but the question is posted so often that I decided to use it, because people need to understand why things aren't working the way they used to work. Why am I not able to do PowerPoint meetings? How come I can't cook a meal out of a recipe book anymore? And so I explain it as follows. I use the car engine as an analog. And in clinical neuropsychology, many colleagues of mine, and I do too, conceptualize cognitive functions from a very high bird's eye view, initially across 4 domains. 2 are steady state, steady eddy kind of domains that are relying on academic, professional experience, your ability to conceptualize, to abstract information. And then 2 domains rely on efficiency. They are more dynamic. So they are responsible for the individual to be able to think fast on their feet, do several things at the time, and use the information that they have stored in an efficient and effective manner. So I equate that to 4 cylinders of a car. If the 4 cylinders of a car don't work together flawlessly, your car does not run very well. It stutters and sputters along. And we find the same thing with human cognition. So if processing speed and working memory, which are the 2 dynamic components of cognition, are not working properly, everything else is going to stutter and putter along. That does not mean you are dementing. It means that the dynamic aspects of cognitive function are affected. Furthermore, as Dr. Astores already was alluding to, post-exertional malaise is something that is hard to understand for patients. So I'm using this cartoon to elaborate on that. As cognitive effort increases to achieve previously experienced goals, it becomes harder when your car doesn't work very well and your energy tank, your gas tank, is not full. So you're working harder to achieve the goals. You're trained most likely to put your best foot forward and just try as hard as you can. So that's what you do. You arrive at point A exhausted. Then you have to rest up. You're forced to rest up. So you're falling down to point B. You're going to try it again because you are trained to don't give up, not give up. So now you have to try harder because your tank is less full and your car is still not working well on all 4 cylinders for your brain. So it's now going to be harder even to get to point C. You're falling further down to D and you are crashing. And that's how post-exertional malaise occurs. So what can individuals with long COVID do to ameliorate the effects of brain fog? Do one task after the other. Do not try to multitask. Cooking is an example of complex multitasking, which most people don't appreciate, and is a source of great frustration for many people. So we discussed that. Number 2, listen to your gut. When the body-brain signal tells you that you're reaching your limit, stop pushing for just one more thing. Sit down and do it at some other time. This is very difficult to do. Learn to do things just below your actual current capacity, not what your desired capacity is. And don't drive on empty. Proper maintenance is essential. Be kind to yourself. Don't beat yourself up over things if you can avoid it. Good days, bad days. You're only human, liable to overexert on good days, then having to pay for it on bad days. What does that mean? You have to clean the windows, you have to go shopping, you have to do all kinds of things that you feel are needed in your everyday life. You had a couple of bad days where you had to rest. Now you're feeling better. So now you front load everything in the day that is better for you. And what happens is what we saw on the cartoon previously, you have harder time to achieve it and you fall deeper, your post-exertional malaise gets worse. Dr. Astores was already alluding to pacing. Pacing is very difficult to learn. It's the acquisition really of a new skill because no person generally is trained in pacing. So it's not something that is the default for lazy. It's really, if you're looking at it as acquisition of a new skill, it's an active process that you have to engage in to move forward. It relies on some universal principles that I'm just going to cite here. You need to control your behavior and not everybody else's behavior, because you can only control your behavior. You need to set priorities and manage expectations. If your family members want to talk to you on the phone for 30 minutes, you will need to learn to tell them, I'm sorry, I can only talk to you on Wednesday at noon for 10 minutes. And people accept that. So you are the priority. You need to establish a routine. If that takes an Excel spreadsheet or a pad or something, then you have to do that. It's generally at the beginning very advisable to just do one major physical or cognitive activity in a day, and that includes taking showers. Utilize the parking lot. Try not to worry about what ifs, what whens, all of these things. It takes up brain space. and it makes your cognitive function even less effective and efficient. And then finally, be kind to yourself. Just sit down. When you don't do anything active, that doesn't mean your brain doesn't work. Your brain always works. So this is not something that is reflective of lazy, crazy, not trying. These are statements that are inaccurate and faulty, and definitely don't apply to any of the patients that I've seen, either with ME/CFS or long COVID. Thank you.
Thank you very much for that. And thanks to all of our panelists. I think we've covered a lot of different dimensions and ground in a relatively short period of time. There's been some very interesting questions and chat going on, and some back and forth with some questions. So I'm going to summarize some of these things and then sort of put some questions to our panelists. And so one of the discussions that's been going on has been what exactly is this definition of long COVID? And the point was made that there are certain organizations that use different timelines as their definition. For example, the CDC uses 4 weeks, the World Health Organization uses 3 months. So along those lines, there was a question that came in that talked about how should someone who has lingering symptoms following an acute infection think about this? Should they worry if their symptoms that they have weeks later are a little bit different than their acute symptoms? Is it more the persistent symptoms that they should be thinking about? And then when does one worry, or what are the risk factors for worrying if I might be prone to developing long COVID? And so some of the questions that came into that, so I'm just kind of packaging some things together, are the individual that's had recurrent infections, or if there's different strains which might be playing a role into this. And so going to sort of circle back to the lingering symptoms and how to think about it in terms of risk factors. And I'm going to open that up to our panelists if they'd like to make any comments on that.
One of the first things I do when I evaluate patients in the long COVID clinic is to make sure that their symptoms are not attributable to other medical conditions. So for example, let me go back to fatigue. So I want to make sure that sleep or any sleep problems are, evaluated, thyroid function, anxiety contributing to poor sleep. So all of those, I need to make sure that they are covered. Now, most of the time I will tell you that it's hard to tease them apart. But I start from there, and we do the lingering symptoms thing is whatever lingering symptom they present with, I will just try to focus on it and say, okay, these are the things that we can use from what has been effective in other treatment populations, and give it a time-limited sort of trial of about 8 weeks, 8 to 12 weeks, and then we go from there. It's very challenging to tease it out. I can tell you that, but I don't know if. But that's the way that I do it in my clinic.
So that is helpful. Any of our panelists want to comment on risk factors, and that might involve pre-existing conditions or other types of treatments they may be on that might make someone more prone to developing long COVID? So
I actually have, it was in one of the slides. Now I need to, this is the thing. So on risk factors, because we do have that information, but I want to pull that up. I'll pull up my slide, and I don't know if I can share this again. I don't. So there will be, it was not called risk factors, but they called it predictors. So this was the slide where it was a graphic about acute COVID and full recovery. So the predictors they mentioned would be demographic factors. So age and sex, we know that we see this for some reason more in women than in men. Medical comorbidities, obesity, asthma, diabetes, the severity, typically higher viral load and severity of the acute COVID, social determinants, and vaccination status. And that we also have data. Long COVID in people who have been previously vaccinated seem to have a milder course compared to people who were not previously vaccinated prior to their acute COVID infection. So I don't know if that is sort of like risk factors, but that's in the fourth slide from my presentation.
Thank you. There were several comments or questions particularly of interest about the long COVID registry. And so there was a comment that was put in with a link to that. So for those who are interested in that, I encourage you to go into the chat and be able to find that. We can re-enter that link for everyone as well, for those who might have that interest. One question that came in, we were so fortunate today that we have our panelists, each of whom is a expert in their discipline, each of whom are different in terms of their medical subspecialties. One of the questions that came in is what kind of a physician or provider can the average person approach if they think they are having some of these symptoms, if they don't have access to one of our wonderful subspecialists? This question was particularly about came from someone suffering from dysautonomia, but I think that same question applies to anyone who might be having some of these symptoms. So I welcome the thoughts of our panelists as to who they might recommend folks thinking about in terms of getting further medical care and evaluation. So Dr. Lang, I'm going to ask you.
Yeah, from my perspective, by the time patients come to see me, either to determine whether or not they have a cognitive issue or because they are going for long-term disability, they've been probably seeing 5 to 9 different physicians. I think talking to them, the best results are support groups and getting information about primary care providers in different states that are educated about long-term COVID or ME/CFS. That seems to be the fastest way to either a diagnosis or to moving the care ahead, the management ahead.
Okay. One of the questions that came in, one of the themes that came out from all of our presentations today was the idea that we are still learning this. There's been an evolution in knowledge as we are going. We even heard about some of the latest research that's come out looking at some newer types of treatments. And so a question came in though about other more conventional treatments, whether they have a place in the management of some of these symptoms seen in long COVID. The question was specifically focusing on antidepressants, but I would think that that same question can apply to other types of medicines that we use for other types of symptoms, and whether that has a place in the patient with long COVID who might be having these types of symptoms.
Well, they've looked at using, so one antidepressant that was studied for long COVID symptoms was fluvoxamine, and that unfortunately did not pan out to be a positive study. But when you asked about other conventional treatments that we can use, improvement of sleep is a big factor for fatigue. So cognitive behavioral therapy for insomnia is an important tool that can be utilized to treat some of the symptoms of long COVID. I regularly counsel my patients to look at ways to optimize sleep. I refer my patients to other colleagues here within UF who would have expertise for example, our pulmonologist who, especially for our patients with more severe initial long COVID, if they have their persistent symptoms, then certainly having a full pulmonary evaluation and treatment for any residual lung condition should be explored. I think that one of the important ways that we can address this is to make sure that we address everything that is related, that is not just to say everything is from long COVID, because and then say that, oh, we're still trying to find out how to treat it, because it is very patient specific though. So it really requires a good longitudinal relationship with a physician who's willing to do that kind of thinking and figuring out with a patient. So going back to what was asked earlier, what kind of physician is this? So this Survivor Core is a patient group. On their website, they have a map where patients can go and identify a center that has a group interested in long COVID. So this could be, so for example, and this will be different per center. So for example, here at UF, I happen to be the one who expressed an early interest in it, but I'm not the only one who is doing that. I just happen to be the one coordinating it. In other centers, it's a pulmonologist and a physiatrist. So that's the Hopkins Center. So the same for Penn, it's also a pulmonologist and a physiatrist. So the lab in New York, the Mount Sinai one in New York is run by an internist group. So it really varies. I just wanted to circle back to that question because I think it is very important. We do not want patients to get what is the word? Hopeless. We do not want them to feel hopeless and helpless, because that is a very bad spiral to be in.
Dr. Jaffee, if I may.
Sure.
So if you look at if you think about what I presented, and the initial considerations that physicians had with COVID was that everything is going to be damaged. We were concerned that the brain was going to have problems, the heart was going to have problems. We've all read about myocarditis. And what we found was there was a normal bell curve of distribution of what actually the virus does to patients. And that bell curve exists within the population. So for example, to a question earlier, if you look at the risk factors for long COVID, we have to translate what we know about other conditions to long COVID to determine risk factors in an early setting. So for example, patients with myalgic encephalomyelitis or chronic fatigue syndrome, what are their risk factors? So patients, female patients, obese patients, patients with a history of diabetes, patients with a history of polycystic ovarian syndrome, patients with a history of anxiety and depression, female patients that have not, what we call nulliparous, which have not had or birthed a child. So we have these risk factors. And what's important to consider is the first day anyone goes to medical school, they say the word history, history, history 3 times. And what a physician determines with this relationship is the history of the patient. And we have to be aware that there's other conditions that can mimic what we perceive as long COVID, or perhaps similar diseases that can be treated the same as it pertains to long COVID. So from the dysautonomia question, I have a patient that responds quite well to selective serotonin reuptake inhibitors like Zoloft. I have patients that we treat commonly like our classic patients with dysautonomia, where we have to increase the way the blood vessels get blood to the body. And we have to be careful as we analyze these things. So it's important that anybody that experiences these symptoms finds a physician and gets in front of them and gives a detailed history. It really seems simple, but a good physician can get all the answers from a good doctor from a 20-minute history just by listening. And so I think it's imperative that you find someone that's an active listener and not a talker, and someone that will take your concerns seriously. And so I just wanted to say that because physicians are human beings. And so it's important to do your due diligence, your research, to find someone that will address your concerns and listen to you.
And that is a wonderful note. I know that we've gone over our scheduled time a little bit, but these were wonderful thoughts. And I think what we're learning together is that this is a complicated issue and that we are all still learning together. And this is the type of thing where we are learning as we treat. I think what I got from these presentations is we're in a different place of understanding and treatment than we were a year ago, 2 years ago. and that the research is ongoing. We talked about it's important to get our people who are suffering from this as partners in this research to help us all learn better how to treat these people. And we talked about some ways of doing that today. And so it'll be interesting to kind of follow this story as we learn more, and hopefully we can kind of see even more refinement of the treatment approaches, and more importantly, the effects that we can get with these treatments as we continue to team with our patients to learn together and come up with better and better treatments for this. So I want to thank all of our panelists who put together such fantastic presentations covering the spectrum. I want to thank the many participants we had tune in today, and for the ongoing dialogue that was coming in both the chats and the questions and answers. I know we didn't have a chance to answer every question, but that just tells us that there's more work to do, and I look forward to kind of following this work as we proceed. I want to especially thank the folks at Health Street at the University of Florida for putting on the Our Community, Our Health series. It's a very valuable series in which we're trying to promote that engagement, where we can work together as a team with our patients. And want to thank the Brain Center for kind of partnering with Health Street and bringing together this very distinguished panel. And as we said before, you can follow the Brain Center on Twitter for future and upcoming activities as well. And so with that, I really truly want to thank everyone today for a stimulating discussion. And I think it's given us even more to think about. And I'm hoping that when the next time we gather to focus on this topic, we'll have even more exciting findings and research, and even more and newer information to share. And we'll have the satisfaction knowing we did it together as a team. So with that, I thank everyone, and I hope everyone has a fantastic day and a wonderful weekend. Okay. Thank you.